Welcome to the Josephson lecture. I had a dream last night that I was supposed to give cardiology grand rounds, and I blew it somehow. And the rest of the time, the rest of the day, Mark gave me these dirty looks. He could do that to you. It's unfortunate that many, maybe most of you, never had any chance to interact with Mark, but he was an inspiration. For those of you that don't know, he went to college at Trinity, where he played soccer and was pretty good. And then he went to medical school at Columbia, PNS, did his medical residency at Sinai in New York. And then, the Vietnam War was still on, and he went to the PHS hospital on Staten Island, where he began studying electrophysiology under Tony D'Amato. And while he was there, he was extremely productive, along with a number of other contemporary luminaries, subsequent luminaries in cardiac electrophysiology, including John Gallagher and just Masoud Akhtar, Jeremy Ruskin. And when he finished his 2 years at Staten Island, he then came to Penn, and I met him when he came in 1973 to begin his fellowship, his cardiology fellowship at HUP. For you Boston-centric people, that's Hospital of the University of Pennsylvania. And he came there because Bruce had been the electrophysiologist, started the EP section there. And a year after Mark got there, Bruce left and went into private practice out in LA. And Mark, after 1 year of fellowship, was made director of electrophysiology. And he, as someone, when he came, I was just starting my internship there in 73. And Penn, I had gone to medical school there. Penn was a pretty quiet place. The cardiology section was quiet. And when he arrived, even as a fellow, the volume and level of discussions there dramatically increased. And wherever he went, that was true of the way Mark was. He could be controversial, but the thing about Mark is that he always based his work on physiology and hard data. And he did his best to advance every area of cardiac electrophysiology based on physiology. And he's had a profound influence as a result because of his observations, his therapeutic innovations. He was the first person to do physiologically based therapy for ventricular tachycardia. And he put the University of Pennsylvania on the map for that beginning in the mid to late 1970s. He came here I remember in 1992, when things kind of went upside down at the University of Pennsylvania. And as you know, started really electrophysiology here and brought it to its current state. So Mark his reputation is well-founded and will hopefully never be forgotten. So where does that bring us to Peter, who's going to speak to us today? Peter got his undergraduate degree at Cornell, did his medical degree at Albert Einstein, and then became a lifer at the BI, doing all his training here. And Peter has established a well-deserved reputation as a leader, especially in atrial fibrillation management, stroke risk, and anticoagulation in atrial fibrillation. And Peter is most appropriate to be delivering this lecture because Mark, for all his basic science understanding, his physiologic basis, he considered two things of utmost importance to him: patient care. He was a doctor, an excellent clinician who listened to patients, examined patients, and he cared deeply about training. And Peter has carried on that legacy and is a master clinician, as Mark would have admired, besides combining that clinical work with his investigations that he's led and continues to lead, especially in the area of stroke prevention, anticoagulation, and atrial fibrillation. So this is very appropriate for Peter to talk today.
Well, thank you, Al. I think that just this bottom right picture was from Mark's 60th birthday. I did a surprise birthday party for him, and there were everybody I invited all of Mark's former fellows who were all over the country, and I think that Al sort of embodies for Mark embodied clinical excellence, somebody who was really fundamentally a doctor, and I think he was one of, Mark profoundly valued Al's role in this division, and I think was really remarkable and able, as Al mentioned, in validating the importance of clinical medicine, which was not so common in those days, and certainly for my career allowed me to stay here. Honestly, I'm not sure I would have stayed here otherwise, because under a different chief, under a more traditional chief in those days. He made a place for me and allowed me to do to form a career that's fundamentally a clinical career. So let me see. This topic is really something that he and I talked about all the time. It grew out of my observations in his clinic. And although this was not the kind of research that Mark did, I think he began to realize the importance of it as we participated more and more in these conversations and trials. So we'll start with a case. This is a 47-year-old woman with no medical history who was found to have asymptomatic atrial fibrillation during a routine colonoscopy. Here's her EKG. So a little bit of coarse, what we would term coarse atrial fibrillation, but AFib nonetheless. No family history of cardiovascular disease, no history of atrial fibrillation. Standard workup, completely normal. This is the pre-DOAC era, so she was started on anticoagulation, and after a month of therapeutic INRs, ended up getting cardioverted, was kept on anticoagulation for a made-up amount of time, which is what we continue to do, because we have no data with that. And in those days, often made a decision about aspirin or not, and she was young, and this was, not someone I expected to have atrial fibrillation, so we sort of gave her aspirin. And then follow-up was determined with me, with primary care. Again, no standard for who follows these patients, sort of up to the patient and the physician. And no standard for how we surveil this circumstance as well. Routine EKGs, pulse checks, et cetera. Now with wearables, we have other options for that. But these are the things that we thought about, and at some level still continue to think about and consider our first principles. We believe, I think appropriately, that most clots in non-valvular atrial fibrillation develop in the left atrial appendage, that it takes some amount of time for left atrial appendage related clots to develop. Again, that amount of time we believed was 48 hours in those days. And that anticoagulation is the best option we have for reducing the risk of stroke. Recognizing that it's not perfect, we look for a 60 to 70% reduction in that risk of stroke. So the pathophysiologic concept is, again, in non-valvular atrial fibrillation, that this results in a period of appendage stasis and clot formation, and then in unlucky individuals, embolization of that clot. And the development of this observation is relatively new, honestly. I mean, it was not until the late 1940s that people began to realize that atrial fibrillation was the cause of strokes. It was predominantly rheumatic heart patients with rheumatic heart disease. The concept that the appendage was the source outside of non-valvular atrial fibrillation was really not determined with any certainty until the 1990s when Blackshear reported this data of 60% association in patients with rheumatic heart disease and 90% with non-valvular AF. And this was an image that was published when I was in training, sort of demonstrating the actual mechanism, the presence of a clot that during TE was transiting into the systemic circulation. And then again, this is something that we all see occasionally, less and less often, but large left atrial clots in the body of the atrium, independent of the appendage, particularly in rheumatic heart patients, but occasionally in other circumstances as well, really illustrating the fact that the appendage is not the only source. So for decades, again, these are the data that we quoted, and I'll refine it in a moment, but I remember Julia Resti telling me when I was a first-year fellow that there's very few numbers you need to learn in medicine as a cardiologist, but you need to know these numbers. When you're talking to patients, you need to have a sense of you need to be able to tell them what their rates of stroke are, because convincing young people to take anticoagulants is not easy. So this was the Framingham data demonstrating a 5.5-fold increased stroke risk associated with atrial fibrillation in the absence of rheumatic heart disease, and obviously a markedly elevated risk in those with rheumatic heart disease. Out of that came the CHAD score eventually, and as I'll show you, this is really a vascular risk score. This has virtually nothing to do with atrial fibrillation, but it's what was developed in the 1980s and has continued to be iterated on over the last 30 or 40 years. But it's it basically has nothing to do with atrial fibrillation. It just describes patients that we frequently see AFib in. And it includes hypertension, again, poorly defined, different ways of defining this. Age, which becomes probably the most important of these risk factors and stratifies pretty nicely over time. And of course, prior stroke and TIA. So now we use this CHADS VAS scoring system. We give 2 points for an age greater than or equal to 75, and obviously 2 points for stroke, although we don't, in the scoring system, try at all to stratify whether those strokes are likely embolic or whether they were just vascular from another source. Of course, we don't have data for renal insufficiency. And really, in the best scenarios, the performance of these tools are very modest. I mean, we are slavishly adherent to this scoring system because we have nothing else. But it's important that we recognize, and I think we should share with patients that this is not perfect. And it's going to fail periodically despite our best efforts. In the most homogeneous populations, sometimes this reaches almost 0.8, but for the most part, it's in the 0.6 range. And it's really designed to identify those that we think are the lowest risk of stroke. So it does particularly well in patients with CHADS VAS of 0, but as it goes up, it's less specific. So like the patient that I presented. So again, here are the data that sort of came out of most of the trials in the 1990s. These are the clinical risks. These are the rates of stroke in clinical atrial fibrillation, and that's atrial fibrillation that presented most often clinically, or at least patients were in it long enough so that they were recognized to be an AFib when they came into their doctor's offices, and ultimately got put into these trials, these anticoagulation trials in the 1990s. And then there's device-detected AF, which is what we're, I think, all contending with now more and more, and we will continue to contend with as patients wear their own wearables more often. Excuse me, and that's AF in that we pick up on ILRs, pacemakers, ICDs, and generally is required to be at least 6 minutes in duration. And that's data from one of the trials I'll show you in a little while, the ASSERT trial. Probably AF that last second should be ignored. Where 6 minutes came from, I think, is less clear, but generally 6 minutes to 24 hours is how we describe the device-detected AF. And it looks like the rates of stroke in that population are substantially lower than they are in those who present clinically with atrial fibrillation. And this may be confounded in a number of ways, which I'll describe in a moment, but again, numbers that are worth considering. And generally, once you start getting CHADS VAS scores of 2 with rates of stroke in excess of 2, that's where a lot of the decisions about anticoagulation, at least from a guideline perspective, have been focused. So we think overall, and we're learning this from we're learning this from a lot of the newer AFib trials that are being done that are turning out to be somewhat underpowered, is that the annual stroke risks are probably dropping. And in part, I think that's because those annual stroke rates that were determined in the 1980s and 1990s were determined before a lot of treatment of vascular disease. So we weren't using statins in those days. And importantly, we didn't start treating systolic hypertension to the mid-1990s. So patients that were in those trials in the late 80s and early 90s, many of them had untreated hypertension for decades potentially. And certainly, I think, results in a different substrate. That being said, the numbers of patients with stroke certainly are going to increase, and that's most notably, I think, because demographics have changed. More of the population is in an older age range, and again, age is the most important risk factor for stroke with atrial fibrillation. Device-detected atrial fibrillation, I think, is a little harder to sort out, and it may be because these episodes of atrial fibrillation are shorter in duration than the AF that resulted in clinical identification. And also, I think what we define as atrial fibrillation through devices is very heterogeneous. So what we call AF based on the electrograms that we see can be very different. So these are three examples with the right atrial electrograms on top and the EKG in those patients below. And you can see that the atrial rates that are determined by a lead in the right atrial appendage in some cases are very slow and don't look anything like what we think atrial fibrillation would look like. The middle one looks pretty much like atrial fibrillation. And in fact, if you look at the ECG in V1 and V2, it looks more like very low amplitude disorganized atrial fibrillation. But on the first and third, like the patient I showed you, the right atrium looks kind of organized in V1, which is closest to what the right atrial lead is looking like. It's quite organized there. It's what we would call coarse atrial fibrillation. And whether or not these are all the same in terms of risk, who knows? We do know that the left atrium doesn't always correlate at all with what you see in the right atrium in people with atrial fibrillation. So again, I think a lot of work to be done there and maybe something that we can tease out a little bit in the future. So this is the therapeutic expectation that we have with the initiation of anticoagulation. And again, this has not changed that much. These are the major trials that used warfarin, some of them against aspirin and some of them against placebo. But we expect a 65% reduction in the rate of stroke in patients that are appropriately anticoagulated. And that requires, however, that the INR be within therapeutic range at least 65% of the time. Which we all know is very difficult to achieve. And so we've ended up with, fortunately, four new anticoagulants, direct oral anticoagulants, all of which showed non-inferiority compared with warfarin, and also showed relatively low treated stroke rates. In fact, most of these trials needed to be expanded in sample size because the initial calculations based on the data I showed you originally turned out to be too low because the event rates were too low. So the RELY study ended up having to add almost 8,000 patients to their initial calculation for sample size, and then the subsequent ones remain larger. The only one that didn't was the ROCKET AF study because the CHAD score in that population was quite high, quite a bit higher than the others. And then we balance this against bleeding risk. And for me, really, the only bleeding risk I cared about or I really factor in usually in anticoagulation is the risk of intracranial hemorrhage. All other bleeding, for the most part, in most patients is non-life-threatening. The uncorrectable bleeding risk that really, for me, is an absolute contraindication is intracranial hemorrhage. And fortunately, that rate's really low. It's much lower, I think, than most of us think about when we talk to patients. And it's substantially lower with DOACs. So for me, the most compelling reason to use a DOAC is to reduce that risk by 40 to 50%, despite the fact that it starts at a very low rate. For a while, people still held on to the idea that aspirin was valuable as an anticoagulant. It took a while to get rid of this concept, and this is just data demonstrating that, in fact, there is a benefit to aspirin. It's about a 20% reduction in the risk of stroke in patients who have atrial fibrillation, but that really accounts for the reduction in their vascular risk of stroke. It's probably not embolic strokes. It's their risk for thrombosis and for the formation of other vascular-associated insults. But certainly not enough, not adequate to reach that at least 65% threshold we mentioned. So here are the guidelines, and these are the most updated guidelines, the European guidelines on the left and the US guidelines on the right. And the only difference really is that the European guidelines have gotten rid of the gender as a factor. And here we use it only once you have another risk factor. Certainly, strokes have higher morbidity in women, but whether or not women are associated with a higher risk of stroke, I think remains somewhat unclear. So a CHA2DS2-VASc of greater than or equal to 2 is a class 1 indication. A CHA2DS2-VASc of 1 is a class 2A indication, and these are places where you have conversations with patients about their sort of risk tolerance. And for me, again, what's the risk of an intracranial bleed versus any other bleed, and an embolic stroke. The European guidelines have added this idea that if you're doing really well on warfarin, particularly in older age, then you can stay on it and maybe should stay on it. Again, I think that's not the practice and hasn't been added here. Aspirin's been dropped from both sets of guidelines. But neither of them really address, I think, a very big factor for us, which is how about all those patients that are inadequately characterized in the CHA2DS2-VASc scoring system, and how do you feel about patients with a CHA2DS2-VASc of 0 who may have something else going on? And I think we look for these groups, and those are, for me, they're young patients. They're patients with potentially lamin or certainly with hypertrophic cardiomyopathy, but then also permanent atrial fibrillation, patients that are 50 years old with permanent AF despite our best efforts. It's hard to view those patients in the same way as we do everybody else, because the average patient with AF is a 70-plus-year-old patient with other risk factors. And this is clearly a very heterogeneous disease. I think we're going to learn more and more that the surface EKG is just a sort of final crude phenotype for a very complex pathophysiology that got patients there, and the stroke risk in those different groups, I think, is going to be hopefully better characterized over time. There are things that we can do to further risk stratify patients from a stroke perspective. And this is an old study. This is a SPAF3 TE study. And this was a study that compared sort of orthopedic dosing of warfarin and aspirin compared with therapeutic warfarin. And it really demonstrates that in patients with very high-risk TE characteristics, the residual risk of stroke is quite substantial, even with dense spontaneous contrast, with diminished atrial appendage velocities, and with complex aortic plaque. So I think we as a division, I mean, Warren pioneered a lot of this work, but we probably should spend more time recording these things and paying attention to this data when we get TEs on patients, because particularly the appendage velocities can be very predictive. There's also that question, as I think was relevant in our patient today. What about the age of onset? Developing atrial fibrillation in a 50-year-old or a 40-year-old is probably a very different disease than a patient who develops it in their late 70s with 10 years of hypertension. And certainly that risk, it may, and I think it probably does identify patients with underlying atriopathies, and that risk certainly could be, and I think is associated with a higher risk of morbidity over time, and certainly in this study, a higher risk of stroke. So our patient presented a year or two later with aphasia and a right-sided clumsiness in an MRI, as shown with evidence of bleeding into a large, what turned out to be an embolic stroke, with another area of stroke on her scan that I didn't show you, but basically multiple areas, making this highly likely to be embolic, with, in her case, unfortunately, some bleeding into that area, and her atrial fibrillation. She was in atrial fibrillation at that time. Everything else was completely normal. She had, again, aggressive workup. She had other reasons for stroke worked up, and anticoagulation restarted once it was felt to be safe to do. And she went through a period of cycling through antiarrhythmic drugs with the hope that if we could maintain sinus rhythm, maybe we would be able to reduce her risk of stroke. And this was in the very, relatively early days of ablation. And with nothing else much to offer her in regard to sinus rhythm, at that point, we were doing a fair number of maze procedures, epicardial mazes that were minimally invasive. And the real reason for doing this was not just for the opportunity to maintain sinus rhythm, but to offer her another form of stroke prevention with left atrial appendage occlusion. So we'll talk a little bit about this. I'm not going to talk about factor 11 inhibitors today as new options, just because the data I don't think is robust enough, but we'll focus on the things we do know about or are beginning to know about: left atrial appendage occlusion, rhythm control for stroke reduction, both of which we thought about for her, and then using AF burden to guide anticoagulation. So obviously, this should not be construed as an absolute way to reduce strokes. This is a targeted therapy for left atrial appendage sources of stroke. It does nothing for all the other myriad of other reasons that a patient in this demographic, an average AF demographic, could have strokes. And this, again, has been a procedure that's been around since the 1940s. It can be done in a number of different ways. The appendage can be stapled or oversewn. It can be amputated completely, or now we have epicardial closure devices. This was a pretty standard part of cardiac surgery until through the early mid-1960s, when most patients were getting cardiac surgery for rheumatic heart disease. And it turned out not to reduce the risk of stroke dramatically, and sort of fell off the map as an option in those patients. And then more data started coming out that perhaps it wasn't effective, in part because clots were forming the left atrial appendage, but also because surgeons were oversewing the appendage. And it turned out that those sutures were breaking, and there was ending up being large communications in those with the appendage, and in fact, strokes were happening in those patients. It got rethought about as an option with the development of this device, of the epicardial device that I'll show you in a moment. So we should, note that it's important to avoid doing oversewing, and this is sometimes what happens with it. This is courtesy of Feroz, demonstrating evidence of a residual stump or opening in the oversewn left atrial appendage, and then with careful approach to this, resolving that. So there's a fairly large connection there. And then finally closing it completely. So this is the endpoint that one would hope to see. And you really need to push surgeons. I think Feroz is doing that now, but without that, this procedure becomes sometimes potentially quite dangerous. Now, the clamp, which is what we use now on the bottom, is a great tool. But again, same thing, you need to be careful to really get down to the bottom of the appendage and in order to have a complete flush occlusion. And that often requires a little bit more dissection than some surgeons are willing to do. There's vital structures around there that can be impinged upon. And it makes it a little bit hard to do this thoracoscopically sometimes. But it's important to be fastidious about it. And this is a clip that I asked David Liu to give me recently. Let's see if I can play. Grabbing the appendage is quite
40.
I'll take about 40.
What are we going outside with this?
Oh, no, she's
Okay.
Pull on that.
Yeah.
40? Okay.
Okay, yeah, I think she's going outside.
Great inspiration is
You see that okay? Mm-hmm. You see it? Yes. That's it.
It's pretty straightforward. It's going to be done, in my view, this should be done on every patient who has any history of atrial fibrillation who goes to heart surgery. It adds 10 minutes to the procedure. And it's now, I think it's becoming standard of care. They're doing it, but you need to, I think as cardiologists, we need to remind surgeons when we send them to surgery that they have a history of atrial fibrillation if they don't know it already. And this should, I said, I think we should be doing routinely. These are the percutaneous options. On the left is the Watchman Flex. This is the most recent generation of the Watchman device and the amulet. These are the two devices that are available in the United States. The Lariat device on the far right is a combined epicardial and transeptally delivered device that actually was in part developed here by Billy Cohn when he was here. The nice thing about this is that you don't leave anything behind. The problem with it is that it can sometimes be very hard to get that proximally onto the base of the appendage, and it's also associated with a very high rate of pericardial irritation afterwards. So it's pretty much, I don't know, there are not very many people using this device at this point. We pretty much are focused on the transvenous delivered plugs. So these are the guidelines right now in the United States. It's a CHADS VASC greater than or equal to 3 with a relative contraindication to anticoagulation. Who can take some type of short-term anticoagulation? These are the protocols. They're evolving, and I think these are the approved protocols. They have to be on an oral anticoagulant and aspirin for the first 45 days, then DAP for 6 months, and then aspirin thereafter. These patients should be monitored for the presence of device-related thrombus. Different centers have different protocols. I'll tell you about ours in a moment. DAPT was approved as long-term therapy from the outset, or initial therapy from the outset in 2022. Sometimes we use low-dose anticoagulation. There are different ways to do this, and certainly has not been completely sorted out. But this is what can happen, device-related thrombus, and this happens somewhere on the order of 1.5 to 3% of the time. They most of the time will develop relatively early, although we've had cases that have been present after a year. And I think Andy Locke and Huey have done a really remarkable job here, developing a really responsible appendage closure program, much more than I think is required, and certainly much more than other programs in terms of stewardship of these patients and following up on them and making sure that we're now looking at a year in everybody because of this concern. I think the truth is that these are material problems. They're issues with material science that hopefully will be solved because they are still relatively thrombogenic. And sometimes you take a patient and you give them another disease by putting one of these devices in because of this risk of DRT. So as a consequence, I think we here are very conservative about who we put devices in, and I'll discuss that in a moment. The other thing to worry about is device leaks, very similar to the holes that I showed you with the surgical approach. And when they're very large, they are absolutely associated with the risk of residual stroke and need to be approached with a eye towards trying to close that off by putting a plug in. So these are the published rates in the Pinnacle Flex study of the new type of Watchman device, the amulet registries, and then Bobby was involved in a sort of more outcomes, real world protocol looking at rates of complications. They didn't look at DRT in that study, in that analysis, just at ischemic stroke. But the rates of DRT are in the sort of 1.5, I think, to 2% range for the most part at most places at this point, with a ischemic stroke rate that's both embolic as well as residual stroke risk for all those other non-embolic sources that these patients get. So we do a 12-month TE here because of a concern for late DRT. Our rate of DRT is about 1.9%, and our rate of having a leak that's greater than 5 millimeters and needs to be addressed is on the order of 2%. So here's some of the data. Many of you have seen this. It's not published yet, but it was presented at the AHA. One of a myriad of trials that's being done looking at left atrial appendage closure transvenously. And This is the closure AF study, so a CHA2DS2-VASc score population of 5, and they were randomized to appendage occlusion plus the standard DAPT protocol, and then transition to a single antiplatelet drug versus anticoagulation. 50% of the patients in this study got the older generation appendage closure device, which certainly had a higher rate of DRT associated with it. But over time and follow-up, and I'm sure for those of you who listen to John Mandrola's podcast, he loved this study and called out the issues with it, but certainly it didn't meet the non-inferiority criteria for the composite of stroke, embolism, and bleeding and death. So I'm sorry, let me just. The systemic embolism rates were low, 0.3% in the appendage closure device and 0.1% per year. Again, I don't know how these were adjudicated. I didn't see them, but any stroke rates were in the 2.5% range, and major bleeding was not markedly reduced on the appendage closure device. So again, a small study, but something that should give us all pause about how generalized, how rapidly we want to go to this intervention. The one place that I think this device has an enormous opportunity in is this sort of belt and suspenders approach, where we combine this in high-risk patients with continued anticoagulation. And for no other reason, patients don't continue anticoagulation, particularly including very high-risk patients. Everybody, I think, who takes an anticoagulant has to stop it at some point. And we know that at least 25% of patients within 2 years of starting anticoagulation will have periods where they have to stop anticoagulation. And we looked at that just peri-procedure here a few years ago when we were calling patients pre-cardioversion and pre-pulmonary vein isolation and monitoring whether or not they had uninterrupted anticoagulation, even without a procedure that may have legitimately caused that to be interrupted. And we found that a non-trivial amount of patients, up to 10% of patients, report that they're missing doses. Often they're taking it wrong. But this is just a common sense issue that's going to happen. So this idea of combining therapies has begun to be looked at, and this is the LAOS-3 study. This was a surgical study taking patients who had a history of atrial fibrillation and are undergoing valve surgery, CABG, or combined, and giving them a left atrial occlusion of some type with anticoagulation meant to be continued, and then versus no occlusion with just anticoagulation. And there was a significant reduction in stroke when these two approaches were combined. So again, in my practice at this point, in a patient with atrial fibrillation who's going through surgery, I find this compelling. I think that they should get their appendage clipped and they should stay on anticoagulation, but this gives us the option to feel somewhat protected when they if they have to stop their anticoagulation intermittently. So the reduction in stroke was, I think, important. It was after 30 days, once the post-procedure issues were resolved. And in fact, the strokes that were associated with left atrial appendage in the LAO combined group were non-embolic. These were adjudicated in a subsequent publication, and overall felt to be lower morbidity with less consequence than we're seeing in the other group. So this is my approach. This is an approach, I think, that I consider for patients that I think are very high risk and for whom I'm considering candidacy for appendage. If they can take short-term anticoagulation, certainly up to a year or more, then they're a great candidate for an appendage device, and then we follow the guidelines. If I really want them to have their appendage taken out because they're having an excessively high risk of stroke and are struggling with full dose anticoagulation, then those are patients that we should be considering for surgical approach. And again, this can be done thoracoscopically. For all patients, I think, with a history of atrial fibrillation that are undergoing surgery, they should get the combined approach. And I will tell you that I have a low threshold for saying atrial fibrillation. And somebody that I think is very high risk to develop AF, I don't think this adds very much morbidity. And more often than not, I've been happy it's been there. And it's given us some peace of mind when they develop AF months later. It may be that eventually we'll move to a place where these can be left atrial appendage devices plus an antiplatelet, given that should be enough for most thrombotic risk reduction, non-embolic risk reduction. But again, we don't have that data. And then I think something that our whole group is doing now pretty regularly is that in patients with a prior history of an embolic stroke despite anticoagulation, or an exceedingly high risk of stroke, and that can mean presenting with a stroke with a low CHAD score who probably has something more going on in regard to risk we haven't identified, has had a history of a clot, has had a history of very dense spontaneous contrast, or that I'm a lot, those are patients that I feel should be offered the option of this sort of dual or belt and suspenders approach. The LAOS-4 study is looking at this question, and these are patients with permanent atrial fibrillation and a modest CHA2DS2-VASc score, or paroxysmal AF with a prior stroke or thromboembolic event, and they're being randomized to Watchman and anticoagulation versus anticoagulation. Unfortunately, this trial is having a lot of trouble enrolling, so it's not clear to me that we'll get this answer, but I've already moved to that in my practice. So the next question is, does AF burden have any effect on stroke risk? Does the frequency and duration of AF episodes correlate with stroke risk? And of course, most of us were trained with the fundamental principle that it doesn't. There's nothing about AF burden in the CHA2DS2-VASc score. You can be an AF for an hour, or you can be an AF permanently, and we treat them the same way in terms of anticoagulation decisions. In the last decade or so, I think the trials have been raising the question of whether persistent and permanent AF perhaps are a different risk group than patients with spontaneously terminating atrial fibrillation. And we're seeing more and more data to suggest that. The TREND study and most importantly, the ASSERT trial published in 2012 began to look at silent AF or device-detected AF and try to quantify an amount of time associated with stroke risk. And in fact, the ASSERT trial was the study that said you have to have at least 6 minutes of AF to qualify as a stroke risk. And they predicted a relatively significant increase in the risk of stroke with just 6 minutes of AF. But in fact, when you look at what the number really was, it was on the order of about 24 hours. This is a subsequent study that they published a few years after the initial study, but it was a fairly significant increase in risk associated with a higher burden of atrial fibrillation. Still less than the 48 hours that most of us were trained on, but more than a few minutes. Now, with both the TREND study and the ASSERT study, one of the big concerns was that when monitoring patients continuously, particularly in these device monitored patients, there were plenty of strokes that these patients had that had absolutely nothing to do with proximate atrial fibrillation. So, that's something that we're going to contend with. And these were not strokes that were adjudicated in terms of embolic strokes or non-embolic strokes. We don't have that kind of data yet, but certainly raise that question. And I think, probably shouldn't be an enormous surprise to us, because the stroke risk in these patients, I think we all recognize, is very heterogeneous. There's certainly the CHA2DS2-VASc related stroke risks, which again, I think are purely vascular risk factors. There's, perhaps lots of circulating factors. All of these have been tested. None of them have ever demonstrated any great predictive value in terms of stroke risk, but an opportunity, hopefully eventually there'll be some sort of circulating or other types of factors that we can use to help identify stroke risk. I think what I believe is going to happen, particularly in patients like the one I described, is we'll learn that these patients have atrial myopathies that we're just not able to quantify right now, that lead to poor atrial function, poor atrial appendage function. Certainly, we know of some of those groups. Patients with Lambda disorders that are 20 years old have excessively high stroke risks. SCN5A abnormalities, amyloid falls into this group as well. We treat hypertrophic cardiomyopathy patients now as absolute indicators for anticoagulation. I suspect there'll be genetic factors. And then permanent atrial fibrillation in a young person. It's hard for me to imagine that this is not underlying some atriopathy that we've not identified. And again, even with a CHA2DS2-VASc of 0, like the patient I described, certainly in my practice at this point, those are people I anticoagulate, or at least offer that to. And then the question, of course, is, does AF burden have a role? And if so, in which patients for guiding anticoagulation? And one hypothesis is that if you take patients with relatively low CHA2DS2-VASc scores, so have relatively few of the vascular risk factors we've discussed, perhaps that can help us stratify. So this is one of a number of analyses showing the same thing, really showing that if your atrial fibrillation burden is very low, but your CHA2DS2-VASc score is high, then you probably just need to be anticoagulated. Conversely, if your CHA2DS2-VASc score is low and you don't have a lot of risk factors for stroke, although the patient I described would not fall into this group, or would dispel this hypothesis, but the burden of AF is high, you should be anticoagulated. So that's what we're thinking about as we look forward to trying to use this as a tool. The AFFIRM strategy, the AFFIRM study was a study published in the early 2000s that, again, demonstrated it was a strategy of rhythm versus rate control, and it sort of put the issue to bed for a long time about whether we could stop anticoagulation, because the stroke risk was increased in patients that were randomized to a rhythm control strategy. It turned out that this strategy was relatively ineffective, and a lot of patients in the rhythm control strategy, in fact, were in atrial fibrillation. But for a decade, we sort of forgot about this whole possibility. What's happened subsequently is that we've developed a better tool for sinus rhythm maintenance than we had before, and that's ablation. And Matt Reynolds, who is at Leahy now, but has been part of this program for many years, did really one of the first studies that raised this possibility that perhaps stroke risk could be reduced by ablation. And then a larger trial was done, and that John Wax and I reviewed for the Annals relatively recently, looking at a large number of patients, trials for AF ablation, demonstrating a fairly robust reduction in the risk of ischemic stroke with ablation. The Ocean trial was recently published. I think most people have probably seen it. 1,200 patients, again, relatively small, and all of these trials are going to be underpowered. All of the intervention trials are going to be relatively underpowered. So we're going to have to look towards, a combination of, I think, a lot of these trials, which I hope will be consistent. I asked Kazi to look at this with me to see whether I could even present it, and as something that we could gauge some of our clinical practice on, and I think it remains relevant, or will be relevant. They used a low dose of rivaroxaban in this study compared with aspirin. They had a relatively high estimated event rate, certainly higher than turned out to be the case. But they found in this sort of average patient population with a CHA2DS2-VASc of 2 who underwent a PVI, 3 years of follow-up, including MRIs, both pre and post-procedure. Only about half the population got it because of COVID, but still the first trial really to look at this. Should I be hitting reboot? Is that the, or is it gonna, or am I just close? Oh, that's a good question. No. Okay, thank you.
Sorry.
Good. So, it showed basically this trial a significant reduction in the risk of stroke, with MRI scans demonstrating really no significant difference, which was something that we've worried about a lot with ablation. But this turned out to be a fairly compelling study to focus on ablation as an early therapy to reduce the risk of stroke. So can we use this data now that we're doing, I think us and most centers around the country are choosing ablation as a first-line therapy for the restoration and maintenance of, or certainly for the maintenance of sinus rhythm? Can we use data post-ablation as well as patients post-antiarrhythmic drug initiation or who are having infrequent atrial fibrillation to guide anticoagulation? So given that the CHA2DS2-VASc score doesn't include this characterization, this is a deviation certainly from the standard of care and requires that we look at this in a prospective study. So we've begun to think about this, and the concept is that now that patients have the ability to have implantable devices, to have wearables that are fairly comprehensive in terms of monitoring, and that we have drugs that we can start and stop quickly, can we use this approach to eventually get to the place like diabetics where patients monitor themselves, start and stop their therapy on their own, and potentially reduce the amount of time that they have to take anticoagulation? So that's the concept, that a patient would do this themselves, that they would interact with their devices, take their anticoagulant or not, let us know perhaps what they're doing, and then manage this in a very personalized way. So we've done two pilot studies in the past. One was with ILRs and one was with pacemakers. We used, I think, pretty conservative approaches for the amount of time that a patient had to have recurrent AFib to reinitiate anticoagulation. And we found that we were able to reduce the time on anticoagulation quite substantially, by 94% in one study and by 75% in another study. So with that, we were able to present that data, and Rod Passman at Northwestern was able to create a study and get funded for the REACT study, which we are an active participant in. And this is tailored to intermittent anticoagulation in a relatively low stroke risk population. So patients that we think are having infrequent atrial fibrillation, can we start and stop their anticoagulation? So these are paroxysmal patients and persistent AF patients with at least 30 seconds of documented AFib, most of the time much more than that, who go on. And at this point, it's becoming a study of probably about 60 to 70% post-PVI patients with a CHA2DS2-VASc score of 1 to 4 without a prior stroke or TIA. Patients have to be willing to wear an Apple Watch for at least 14 hours a day. And they have to have an Apple phone, because that's how the device interacts with the app that we have is only for Apple phones. They're excluded predominantly if they have atrial flutter. That really becomes the major problem with randomization at this point, because flutter is very hard to define and screws up the Apple Watch detection pretty substantially. And these are just a couple of patients from my clinic. Any regular rhythm is going to be missed potentially by the watch, and even slow episodes. Some slow episodes of atrial fibrillation will be missed by the watch if there's regularity. So that becomes an issue when we exclude those patients. But the vast majority, particularly given the amount of time these patients are being monitored, the majority of them will get picked up. So it's a one-to-one randomization, and the study is either you get randomized to continued standard of care, which is a DOAC, or to the treatment arm, which is an Apple Watch guided DOAC use. They get monitored continuously. All the data goes to UCSF, to a monitoring station. If there's been we're looking for continuous AF that's greater than an hour in a 24-hour period. If there's none of that, you just continue in the cycle, withholding anticoagulation. If there isn't an hour that's identified, then you go back. If the patient gets identified, gets contacted both by the app. If they don't respond to the app, they get called, and they go back on their anticoagulation, and then the monitoring process continues until a period of quiescence develops and they can come off their anticoagulation. The primary endpoints are stroke and ischemic stroke, embolism, and secondary endpoints are major bleeding. So the goal is about 5,000 patients. I suspect we're going to have to the enrollment's going well, but it's behind schedule. There's about 2,500 patients enrolled so far. We've enrolled 105 or 110 here. We'd like to get, our goal was to get well over 200 from this site, so hopefully we can pick that up. But it's I think going to become even more important than I had thought when we were doing this trial initially, because of all of the data that's come out of ablation. So this is what the patients get. They get a push notification telling them the status of their rhythm, and if they know that they have to be restarted, they then communicate back with the app so that we know that they got the message and they're reinitiating anticoagulation. And if they don't do that, then they get reached out to. So in conclusion, I think the state of things at this point are that the overall stroke rates are probably lower than we once thought, although we remain really inadequate at identifying which patients are at risk. And there are patients like the ones I presented who should never have had a stroke based on any of our criteria. She subsequently has developed basically, in spite of all our efforts, in spite of the maze as well, she's in chronic AF and has been now for years. So she undoubtedly has some sort of underlying atriopathy. We sent her to Usman to get genetically assessed and see whether we can find anything. Our ability to accurately assess this risk is low. I believe that appendage occlusion should be viewed as an adjunctive therapy to anticoagulation. The only patients we consider it in as a standalone therapy are those patients who have really an absolute contraindication anticoagulation, who are not going to take anticoagulation irrespective of what we recommend, but are willing to consider some form of low-dose anticoagulation in continuation with their device. A reduction in AF burden, I think mostly driven at this point by PVI, certainly is reasonable to consider when you're talking to patients about reasons to undergo a procedure. I think that this now is something that we can offer or begin to offer as a potential dividend in addition to symptomatic improvement. And then withholding anticoagulation based on the presence of sinus rhythm, if we can do it in real time, and that's really important, that patients are willing to wear watches, that we can enroll them in a trial and ultimately continue a strategy where they're looking every day for a significant amount of time, may turn out to be a viable therapy. So with that, I thank you.
Thanks, Peter. We can have questions, and if you let me ask a couple. So PVI seems to be associated with reduction in risk of stroke. Are you now taking patients of yours that have had PVI and any of them stopping oral anticoagulation?
Sure. Yeah, so for patients with a CHA2DS2-VASc of 0 or 1, where there was that, it was where we've always thought it was reasonable to have that conversation. I have a low threshold to stop anticoagulation in those patients. Oh yeah, so I mean, I think the answer. So how long after the procedure? I think we have no idea. It becomes a practical concern issue. We use 3 months. Traditionally, we've used 3 months because that's what the surgeons use. That number came out of the post-Maze literature, which is, different than what we do because there was a lot of post-operative inflammation and a high recurrence rate in the first 3 months after surgery. So we use at least a month. Most of us use 3 months. I think from a practical perspective, because the risk of recurrent PVI of AF and maybe needing a second PVI is highest in the first 6 months, I tend to use 6 months. But beyond that, let's say you're at a year, I think in patients with CHA2DS2-VASc of 1, I'm comfortable stopping it. The question becomes like when they reach 75, PVI is not a curative therapy. So all of this, I think the conversation has to be, maybe we'll stop it for now, but we're going to watch you every year and this isn't like we took your appendix out and we never need to see you again. It's an evolving disease. And I think that has to be explained. And most of these patients at some point are going to redevelop AF. That's just the fact. And they may develop it when they're much higher stroke risks. So I think that's a really important part of the conversation to have.
Jenna?
Yeah. Yeah. So the question is, when do we do TE in patients who have been anticoagulated? I think you don't have to do it in anybody unless there's specific circumstances. I mean, the issues that come up for us are someone who's been on appropriately dosed low-dose DOAC. So they meet all the criteria to be on 2.5 milligrams of apixaban. The problem is the data for low-dose DOACs is horrendous. We wrote a perspective on this a number of years ago. There's really very little data. There's one trial that actually looked at it and that was small and underpowered. Most of it's sort of real world data that's hugely confounded. There have been sub-studies of the major trials where patients were on these low-dose agents, dosage appropriately, where there have been cardioversions and they reported those outcomes. But for me, almost everybody who's on a low-dose DOAC is high risk for stroke. And we have a protocol for what to do. I try to increase them to full dose for at least 10 days to 3 weeks before the procedure. And the highest risk of stroke post cardioversion is in the first 10 days. That's also data from Warren. I try to up their dose if I can, if I think it's safe to do that. Other groups like you're describing, that are potentially particularly high risk with dense spontaneous contrast or prior clot. Again, I think if you know that they've been taking anticoagulation consistently, you're not obligated to do that, and I don't routinely. What happens often is that we wonder whether they've missed doses, and patients are often not as convincing as you want them to be, and so we do it on a case-by-case basis. Yeah. Nick? Okay. Sorry. Yeah. Yeah, I think, look, I think that to me, age is the most important of those risk factors. So it certainly depends on the age of the patient, So a 64-year-old whose CHA2DS2-VASc is 0, it's different, but I don't have a specific thing. I tend to see patients I want them to be seen annually. We used to tell them to try to teach people how to take their pulse. I think that's pretty fraught, but now with devices, I think everybody's getting an Apple Watch. I tell everybody to get Apple Watches. There'll be lots of different options over time, but I think that's changing, how we do surveillance. But I think the critical statement is that you're going to get it again. No, it's never a one-time problem, and I don't think we're curing people with AF. I think we're knocking it back often for a decade or so, but we're going to see a lot of people just because the atrium is evolving. It's becoming myopathic just as a function of aging. That's going to be a trigger for recurrence of this. Yeah. Yeah. So the question is, like this patient, how do you approach somebody that clearly looks different than the typical atrial fibrillation patient? What's the evaluation that you do for those people? Again, I look for all these. I like this stuff, so I think a lot about about how the AF may be an epiphenomenon of another genetic syndrome, and we're seeing more and more. We're learning more and more about those. I think lamina is the one we worry the most about, just because the stroke risk is so incredibly high. But yeah, I mean, that's when Rob got here, the first thing I wanted him to do was build a clinical genetics program, for that reason. And I think we have a great one now. And I think I have a low threshold to talk to Usman Prashant, about whether it's worthwhile. So that's certainly part of it. I think from an imaging perspective, yeah, a lot of these patients get MRIs. I look for excuses to do it. I can't say it's that actionable right now. I think, but yeah, I think you got to keep asking these questions every year, because you learn more from patients. You get more family history all of a sudden that gets integrated into how you think about them. But I think, we have a tendency, certainly electrophysiologists now don't want to see anybody. Most programs are different than ours. They have zero interest in seeing people in follow-up. And I think that's okay if right. So, right. But I think that this is we need to think about this. It's a hassle of a disease, but I think there are subsets like this that we have to have some humility around our lack of understanding. Yeah.
Question, that beautiful summer slide, left side, the heart, electro. We had this, but
Yeah.
sum up every one of the it's still a small group.
Yeah.
They are that's another blood stuff.
Yeah, I think so. But the question is, what kinds of strokes are those patients having, with all of those other factors? I think that they're not, are they having embolic strokes? Are they are they in association with the atrial fibrillation or not? And I think, yeah, like I think that's stuff that could be done. I think that could be a trial like that could be done if there was an AF consortium across this country that was, you know, there was an attempt at that when I was junior faculty. Actually, it was run by somebody at the MGH, and we participated in it. We were getting blood on every AF patient and following them. She was looking at, you know, at Karen Fury, I think. I'm getting her name wrong. No, not Fury, but there was somebody at the MGH who was a stroke neurologist. But anyway, they looked at all the usual things, many of the things that were there, and it turned out the event rates were too low and they couldn't get enough patients to really have it be meaningful. It's going to happen at a national scale, I think. Good. All right, good. Thank you.